All right, thank you everyone for joining. Again, as Chantry said, my name is Jeremy Hustead. I've been doing this Echo for about 2 years since it started, but I'm glad to be here. I thought winter was over with, and then I got surprised on Monday when we were visiting a family and trying to drive home in that mini blizzard we had. But glad to be here. Glad we have some sunshine, and I too am a bit pale, so we'll see. But this topic, it's a big topic, as Chantry mentioned. It's fundamentals of drug testing, reality meets limitations. So that is me. My background is I work at WVU in the RNI, medical director of outpatient addiction intensive outpatient program. This is with Laura Lander. Her and I run it together. So I serve as the Addiction Medicine Fellowship Director. So our trainees that we have come through, they can be from different specialties, not just psychiatry, but we've had OBGYNs, ER docs, OCMED, all kinds of different interesting people come through our program. We teach them about addiction. So I'm pretty involved in addiction work. I work for, not for, but I volunteer with West Virginia Society of Addiction Medicine. Some of you are familiar with the American Society of Addiction Medicine, so it's kind of our state chapter of it. Special mention on the slides, although she's not here today, so Dr. Danielle Tacker. So she is more or less our WVU medicine drug testing guru, someone who helped me develop these slides and kind of be able to just explain to people a little bit more about drug testing. So she runs all the drug testing we do here. She's kind of high up in the area of drug testing and pathology. She is pretty easily accessible if you have direct questions about the testing themselves. I try not to get too much into the weeds of how the testing is done because it's pretty complicated stuff. But she's an absolute genius when it comes to this. And when we've had some novel drugs come about, like for example, some of the delta THCs, she's literally the one that developed the test so we could test for it. So disclosures, I have no financial entanglements with any pharmaceuticals, insurance companies, and certainly not any drug testing companies. So I'm kind of saying this as my own experience. I've done some expert witness work before, but it's always been purely pro bono, so I don't get paid to give testimony. So if you've ever, I don't know if you've ever seen me in court for some reason, I haven't done that many court appearances, but I'm not getting paid to do it. No, it's basically meant to support any patients we have, or there's been confusion in the courts. So being willing to try to serve and inform and educate. My goal here is to shine a light on the possibilities, but also limitations of drug testing, because there's certainly good things about drug testing, things we need, but there's also limitations that I don't think are always appreciated. I was actually spurred on to learn and testify on this topic after having it affect our patients. So I've my original desire to start doing presentations did come out of a patient that was negatively affected in the time it was a drug treatment court. This was like 7 or 8 years ago, but from there, just seeing different experiences that our patients have gone through and really helped me to realize this is an important topic and one that's again not fully understood even by people who practice medicine. So, some disclosures of personal beliefs. I do not believe that everyone is a victim of circumstances. So, there is that idea sometimes thrown around that anyone that struggles with substance use or other criminal behaviors, that they're just the victim of their circumstances. I really don't subscribe to that. I do believe that illicit drugs are bad for individuals and society. You could argue that some legal drugs like alcohol and tobacco are even worse for society, what they do, the number of people that are affected, DUIs or death from COPD or lung cancer, things like that. I also believe that proper law enforcement is needed to protect society, and within law enforcement, certainly, CYS services. I also wholeheartedly believe that addiction is a brain disease, but also personal choice plays a crucial role in addiction. So it can be both things. You can have the disease of addiction, but also there's obviously choices on top of it. So it's not one thing or another. I also do believe that many institutions, practitioners, pharmaceuticals, and testing companies are taking advantage of our current substance use crisis. So many have seen that there is a spotlight now on how many people have died of overdose. and how much money is being thrown around with the opioid abatement funds, for example, and they kind of put their hand out saying, I want some of that. I also do believe that some jurisdictions are being misled about drug testing. So that's a large part of why I wanted to give this talk, and I've given it before for different peoples. So the objectives of the talk are: one, review the facets of drug testing and its limitations, so the testing itself. Two, highlight some concerns on over-reliance of drug testing, because that can be a problem. And then three, provide some clinical examples if we have time. And it sounds like we probably will, since we didn't have any overt cases, but we'll kind of have cases that I sort of created and we can discuss. When we're talking, if you have any questions and you want me to answer them quickly, just I think Chantry, you're keeping an eye on the message box, so I'm happy to like pause and go. If we're pausing too much and we have to speed up a little bit, I'll let you know. So a key understanding of any drug, of any test, whether it's a drug test or a test for diabetes or blood, any test really, is that no medical or forensic test can ever be considered 100% accurate or reliable. So there's no test out there that says absolutely this is the perfect test made ever, that it's 100% correct 100% of the time. It's impossible. Every test performed has limits on it. So on its a sensitivity. So a sensitivity is the ability to detect something is there. So you say, is it there? Is it not? So is there a disease that's there, like diabetes or cancer? Is there a substance present, whether it's prescribed or illicit, etc.? The other thing, specificity, is the ability to accurately differentiate one thing from another. So sensitivity is basically saying, uh, we believe that this is there. Specificity is saying, okay, you believe it's there. How do you know it's not this other thing that looks a lot like it? So how do you know it's cancer and not a benign tumor that's not going to kill you? The manner of testing methods and the established cutoff levels highly influence how we judge the reliability of any clinical or forensic tests. So kind of where you set the metrics. So where you're saying, okay, this cutoff or that cutoff makes it more or less specific or sensitive. So these are all things that go into when you're developing a test, is saying, how sensitive do I want it to be? How specific do I want said test to be? So no test is perfect. Every test represents a compromise. So there is no test out there that will 100% accurately pick up everything all the time and never give any false positives. It's literally a statistical impossibility for that to happen. False positives and false negatives. So a false positive occurs when a test says that something is present when in fact it is not. So that makes sense. It's a false positive. So the test says it's positive, but it's false. The reality is that thing doesn't exist. The disease isn't there, or the drug isn't there. False negative is when a test reveals nothing. So the test says it's negative, but in fact it is there. So just the exact opposite. Every test has a concern for both false positives and false negatives. So they do exist. Again, it doesn't matter if you have the world's greatest test. There's the possibility that you are going to pick up some things that really aren't there. Sometimes that's called noise. And you're also going to miss some things that you should be picking up. The nature of the test itself and the setting of the cutoff levels typically determine these factors. So basically how much false positives, how much false negatives are you going to tolerate in your test that you develop. In general, the more sensitive the test, so the more you're trying to catch kind of everything, the more sensitive it is, the greater the likelihood of having false positives. So the greater the likelihood you get noise. Conversely, the more specific the test is, so the more that you are trying to boil down and say, okay, is it 100% that thing that we think it is, that adds a greater likelihood of false negatives, so that things are missed. Yeah. One of the things is an extremely low cutoff point, which is often used to promote forensic products. This also induces a greater likelihood of false positive results. So the idea is what we see in testing, we've had this happen clinically, is we've set the cutoff basically too low, and then we start to pick up noise. So what can kind of externally be thought of as a positive can actually turn out to be a negative. So if you set a cutoff level so infinitesimally low, you're going to pick up some basically junk. And that can be very misleading. And I know from a forensic side, because I've been to these conferences, spoken at, probation services, and I know a lot of products get kind of advertised, and their claim to how effective they are is how low the cutoff is. So it's not necessarily by itself a good thing. We should always be skeptical, especially when testing companies promise too much. So if they do say, "Hey, my test is the cat's meow, it's the best thing since sliced bread," that should really raise up some red flags because, again, doesn't matter how good the test is, there's no perfect test. All right, spoken for about me. Screening versus confirmations. So what are they? Drug screens are initial tests used to detect the possible presence of a substance. So we're basically looking to say, is it possibly there or is it possibly not? Screens are typically immunoassays, which are quick and sensitive, and you could also put cheap in there too. So the idea is you're trying to not add too much cost to the system, whether it's clinical or forensically. What they generally use is antibodies to detect certain shapes of molecules. This is very similar to what you'd say see with a pregnancy screen. So based on a pregnancy screen, dip test, you're never going to say, "Oh, I'm guaranteed to be having a baby at such and such time." There are other things like cancers that can actually light those up as being positive, or the test itself can potentially be incorrect as well. They are more prone to false positives, but generally detect everything you're screening for. So if you don't have an antibody against it, you're not going to find it, right? So if you're not screening for, say, fentanyl, you're not going to see it on a test. Right? Drug confirmations, what those are more in-depth follow-up tests and used to verify and identify specific substances. So the classic thing you'll see listed is gas chromatography mass spectrometry, or GCMS, and or liquid chromatography mass spectrometry, LCMS. So you'll see it often listed as like GC-LCMS. So these are the most common confirmation tests available. The basic way to explain these, they're almost like a complicated sorting method to compare the samples of standard molecules. So what you'll do is you'll develop a list of standard molecules. So you basically teach the test like, hey, this is what fentanyl looks like. This is what Xanax looks like. This is what that looks like. And then you're trying to compare it to what the screen shows. So if you don't have a kind of a standard molecule, so let's say somebody comes up with a new drug of abuse that's just flooding the market, but no one's ever seen it, you can't really test for it even on a confirmation. So the confirmation itself is not so smart that it can go in and figure out exactly like what's present. It has to basically take a picture as it's going through and say, okay, that looks a lot like this, which I've seen before. I hope that makes sense. Drug testing considerations. This is from my buddies at ASAM, so a few years ago. So drug testing is a powerful monitoring tool used by clinicians, law enforcement, etc. In clinical addiction medicine, drug testing provides us with objective information about a patient's recent use and also allows feedback to their treatment progress. So a lot of times we tend to use drug testing not so much as a stick to beat people over the head with. We try to use it more as a way to talk to them about, okay, are you using? Are you doing well with your treatment? Do we need to change your treatment? We're less prone these days to kind of kick somebody out of treatment unless we suspect that they're diverting or doing something nefarious with the medications or illegal in general. That's a way that will quote unquote kick somebody out of treatment. But in general, we use it more to guide care. All right. Drug testing also, and this is something that's known nationally, can be used inappropriately, incorrectly, or unethically, leading to potentially adverse outcomes in patients and system waste. So one of the things with system waste is if we wanted to, for instance, I mentioned the IOP program, we generally will test people once a week, sometimes twice a week. If we wanted to, we could test somebody every single day, force them to come in every single day. In doing so, other programs have used that to actually increase, the payout for Medicaid. So I know of rehabs that have gotten serious trouble with Medicare by trying to test somebody multiple times a day. So you can do that if you want to. But what's the point in drug testing someone multiple times a day unless you're basically trying to raise up laboratory fees?
Hey, Jeremy,
So yes, I'm sorry.
there's a question. So,
Yes,
is it possible to test for kratom use?
it is. It is, but it's this very specific test. So the one that we have here, for example, that we use clinically, we're only testing for metragenine, not necessarily the metabolite of 7-hydroxymetragenine, i.e. 7-OH. So it depends on what laboratory you're looking for, but sometimes when it says more novel psychotropics, you really have to, search for the lab to test for it. A test, just because you send it off to, again, LCGMS, it may or may not have that as a standard molecule to test for. Even if you ask for it, sometimes certain laboratories may not even have that listed as a possibility as a test. So it really depends on where you're sending it to, who's testing it, what they're looking for. Are you looking for the drug itself? You looking for the metabolite of the drug? It's complicated stuff. So it's possible. Again, we can test for like one form of kratom here. All right. So how do we approach screens? So typically screens are randomly and routinely performed to detect adherence and or misuse. So not only are we looking for, hey, is someone potentially abusing drugs, but we're also looking, hey, are people taking their medicines? So it's kind of both. We try to avoid making any decisions based on results from the presumptive tests, so just the screens, which have not been confirmed by the patient nor with definitive testing methods. So if we do a screen and someone says, yes, I used, the screen shows it, generally we say, okay, that's pretty much good enough. But if someone does a screen that's positive and they say, I absolutely have not used, we're not going to really kick them out of a program until we get confirmation testing. For example, we were doing a research study and we were having patients that were testing positive for fentanyl who clinically looked fine. We couldn't figure out what was going on. It turned out that those people were all on trazodone, which is a non-abusable sleep medication, and that was causing their false positives. The way we realized that we confirmed is one of the staff was on trazodone. We had them take the test, and guess what? They were positive for fentanyl as well. So we try not to make you know, major decisions based on just the screen alone because it can be misleading. Presumptive tests have significant issues with accuracy because of both false positives and false negatives, which can but should not affect clinical decision making, as I mentioned. Definitive confirmation testing may be used to detect specific substances not identified by presumptive testing methods and to refine the accuracy of the test results. So, really, the definitive or confirmation testing is what we generally rely on, unless somebody has said yes, and clearly I'm using. So, screening is good and necessary, but clinically, we avoid making decisions based on screens alone unless our patients admit to use. One of the I was just talking to some of you all may know Dr. Lloyd. He's kind of the drug czar now of the state, and he said he met somebody in jail who actually had been placed in jail based on a screen result. So their test was positive on the screen. I guess they violated probation. They ended up 10 years in prison, capital P prison, based on a screen that was actually a false positive. Pretty wild. So it can happen. What is the current gold standard of drug testing? So what do we actually test for? What do we consider to be the gold standard currently? So observed random urine drug screens with sensitive immunoassays. So that is the initial gold standard. So random urine drug screens with sensitive assays. So we're trying to detect things. We basically are allowing for a higher likelihood of false positives and we're trying to reduce the amount of false negatives. So very high sensitivity, pretty low specificity. If an unexpected result arises and or there are substances of interest not screened for, those samples are sent off for the confirmatory GC LCMS. So if we see it or something for some reason our screen does not pick it up, like for example, kratom, which was mentioned, we will send it off for confirmation. If the confirmation is strongly positive, it is extremely reliable. So if you get it back and it says, the number is pretty high, way higher than the cutoff level, that pretty much is as good as gold, unless there was some, horrible collecting issue, which can happen, like samples got switched or something. I've seen it. But if it's strongly positive, it's very reliable. You can pretty much bank on it. Now, if something is weakly positive or you have confusing results. So, for example, if you see a drug but not the metabolite of the drug that should be there, even the GC LCMS can be unreliable. So if somebody's, the cutoff is 1 and someone's 1.5 or 2, I wouldn't necessarily bank on that being a positive. I would want to confirm that. Even clinically, when we see those really low ones, we're kind of like, ah. So I've heard it said a positive is a positive is a positive. I would kind of say it's a positive test, but what does it exactly mean? We should always be skeptical about what any lab test means. So limitations that you see with drug testing, especially urine tests, are that you can have false samples or diluted samples. The detection windows, every drug is going to have a different detection windows. Actually, sometimes blood tests have shorter detection windows than urine tests, which is interesting. So urine, in theory, is kind of better when it comes to detecting. The false undiluted samples, we can generally tell because there are safeguards with the samples themselves. We can see if something looks weird, things like specific gravity. We're looking for to see is this actual urine or is the temperature off? Has somebody used someone else's urine? There are different ways that we can do it. Despite some limitations, the gold standard remains urine and not sweat patch testing, which I'm sure you guys have probably seen advertised. Hair follicle necessarily or dried blood tests, which all use similar testing but different collection methods. So these other things do exist out there. You've heard of them, but they are certainly not considered gold standard. We just had the Olympics, like a month ago. Nobody there was getting sweat patch testing, to see if they're juicing, right? Everybody was doing observed drug screens and actually two samples. So if the sample A was positive, they always get sent off for sample B. That's the way it works. So some drug testing concerns, things that we see that I worry about. Overutilization of testing for financial gain or misinterpretation is a real concern. I mentioned some places will purposely test somebody ad nauseum to rake up the bills. Misinterpretation is definitely also an issue. This stuff can be very complicated and it's very easy to just see a number. And I mean, I've seen this clinically with very experienced physicians where they read the test wrong and they think it's positive. And then you're like, no, that was, it's saying it's not supposed to be positive and it's not. But I've seen it. Multiple treatment centers have been caught over testing to bill more, as I mentioned. Constantly testing is wasteful and rarely adds anything to the picture. So if you test every day, you're not going to really detect anything you wouldn't find by testing every 3 days, for example. There should be context to the results. Results in isolation can be misleading. So screen substances of abuse can also be given by EMS or hospitals. I've seen times where people had a seizure in the field, and the classically EMS, if someone has a seizures, will give Versed, which is a benzodiazepine, midazolam, and they'll often also give fentanyl. So fentanyl to somebody having a seizure. Once they get to the hospital, and let's say they get a drug screen, or the day later they go to probation and they test, they will be positive for both a benzo and fentanyl. So again, it can be a little misleading if you're not sure what's going on. False positives can occur both on screens and even on confirmations, which I mentioned. Testing is complicated. It is very good to have independent, neutral evaluators. So, really not having someone who has quote unquote skin in the game. If I think some of the concern we have at times is that people are kind of looking for or looking for positives, not necessarily false positives, but they're looking for positives, and again, they don't really have anybody to kind of step back and independently look at these tests. One of the concerns also is recently entrepreneurial laboratories have been selling questionable testing methods that are proven expensive and misleading. So that is something that we are seeing. Again, I mentioned some of these conferences I've been to, and you see that 9 of the 12 booths are various testing methods, and they're sponsoring the conference or whatever. I get it. I see it in medical conferences too, but it's certainly something to pause and be concerned about. So healthy skepticism of testing methods and testing results. I really do believe it is our duty to be skeptical of every testing method we utilize and every result we find, be they positive or negative. So anytime I see a test, if it's negative, I still pause and say, hey, how does that compare to how someone looks clinically? And if they're positive, I'll also say, does that reflect what I see clinically? Are the results extremely positive? Are they kind of borderline? Are they questionable? So these are all things that we take into context. Keep in mind it's a much different outcome, however, when you have false positives or a false negative. So if it's a false negative, so the test says that it's not there, but someone is in fact using, or someone, they're kind of getting away with this, they're skirting around it. That generally means that someone is temporarily getting away with it. I had one of my physician mentors years ago. I remember him saying something along the lines of, if someone is using, they can only hide it for so long. So they're going to look bad clinically and they will slip up on a test. You can't really hide it forever. So false negative generally means temporarily, quote unquote, getting away with it. With individuals struggling with use, it is difficult to continuously hide instability. So, someone is actively using, they're going to look pretty bad. Clinically, there will be many other signs of impairment with ongoing substance use. On the other hand, if we accept something as a false positive, accepting a false positive as truth potentially means someone going to prison or losing custody of their child. So, when I see a positive, I would say I have more pause for concern about the testing itself, questioning, hey, how is this collected? What do the results really say? Because if we are saying someone's using, that could have much more serious outcomes than if somebody, quote unquote, gets away with it. I will say few things are more demoralizing for a patient than being sober and getting accused of use. I've seen it before. I can think of one instance where a lawyer told me that his client was being accused of using when he wasn't. And basically, the court said you have to admit to use, or you're never going to get your kid back. And so the patient perjured themselves and said, yes, I'm using because, and I promise I won't use again, to get their kid back. And then they ended up taking their kid away anyways. So I just can't imagine doing that kind of lying because everybody says you're a liar, you're a liar, you're a liar. Look at this test. And it's just the test that's bad, not necessarily the person. The other thing is it can trigger mutual mistrust between the parties. So again, if we're saying someone is using, or my doctor saying, you're using, you're lying to me, and someone's really not, it's just a bad test, that's going to trigger some major mistrust between folks. More skepticism of these test results. Neither situation ideal, but let's keep in mind the legal axiom. I'm not a lawyer, but the legal axiom is innocent until proven guilty. With people who use substances, what we often find though is that they can be treated like they're guilty until proven innocent. So, it's like you've been caught, you're a drug addict, quote unquote, you're a drug addict. Now you have to prove yourself not once, not twice, but 1,000 times over and over again that you are no longer a drug addict. So it's a kind of a different way to kind of look at people. The goal of drug testing really should be accuracy, not simply finding more positive results. So our goal with any tests, whether it's drug testing or again cancer testing, diabetes testing, whatever it might be, is we want to try to get accurate results, not just finding as much positives as possible. If we set cutoff limits too low, we will just start detecting more and more noise, such, for example, as poppy seed bagels. So poppy seeds, as the name implies, use poppies. Poppies are how you make most opioids. Fentanyl is not made by poppies, it's synthetic, but poppies do contain trace amounts of morphine and codeine. So if I sat down, ate a cup of poppy seed bagels, and then took a test with extremely low cutoff, you will see morphine and codeine in my system. That's just the reality of it. The goal of ethical drug testing should be to have the most accurate testing results possible that reinforce really the clinical findings of either stability or impairment. So we want to have our clinical picture, someone's looking good, they're doing well in treatment, or they're doing well with all their CPS case, they're doing all the stuff they need to, their test looks fine, Okay, that's, reinforcing. Or B, they're not doing well, they're skipping all the things, the visits are going poorly, and, the tests are positive. We're trying to reinforce what we see. So concerning false positives, so again, I mentioned false positives really have to be considered a worse outcome than false negatives. Neither are good, but false positives, you'd have to say on the scale is worse than a false negative. False positives typically occur when our tests confuse one substance for another, showing something present when in reality is not. So they kind of get confused. Let's say cold medicine. Thankfully, I got over my cold about 2 weeks ago, but I was taking cold medicine regularly. I'll bet you if someone tests me for amphetamines, it'd probably show positive because I was on the one phentermine, the one medication that's in what's that? It's actually phenylephrine, not phentermine, but phenylephrine, very similar to phentermine, so that can show up as a positive on an amphetamine screen because they're closely related. Urine drug screen remains the gold standard of testing. Newer tests such as spot testing have less robust validation and collection concerns, so that's something we have seen. Typically, newer testing methodologies are patented and not externally verified. So one of the things that we've run into is that when we hear about a test that's being run on patients and we try to figure out like who's running them and how they're doing it, they won't actually talk to us. They won't talk to, say, Dr. Tacker, the clinical people that know how these things work. So they're kind of like independent in their own little thing, doing their thing, and not really telling us how they're getting these results, which is worrisome. Many over-the-counter OTC and prescription medications can cause false positives. As I mentioned, things like, for example, fentanyl. So trazodone, sleep medicine, not addictive, very commonly used, can be a positive. Risperidone, false positive, another antipsychotic. Even something like Benadryl, which I'm sure probably all of us have taken at some point, that can sometimes show up as a false positive for fentanyl on a drug screen. So don't get too overwhelmed with this. This is more of a slide for reference, but just some things out there, kind of put it in context. But NSAIDs, so that's like ibuprofen and Aleve, and proton pump inhibitors, that's like your Prilosec, things like that. That can show up as marijuana metabolites. Cocaine. So if you have topical anesthetics containing cocaine, so what are topical anesthetics that contain cocaine? You can have things like Oragel, that's very similar to cocaine. That could confuse it. I mentioned poppy seeds, poppy oil, some antibiotics. Those can actually show up as opioids. Dextromethorphan, that's cough medicine. All right. Amphetamines, many things that I mentioned. Phenylephrine, that's the one that I was taking in my cold medicine. That can show up. Some of the old, there's Prozac right there. Very common medicines. Wellbutrin, super, super common. Bupropion, so super common, showing up as an amphetamine. Sertraline, that's your Zoloft, showing up as a benzo. Those are NSAIDs, like I mentioned, you can literally buy at the store, and those might show up as barbiturates. Other things can show up as methadone, that's Seroquel. Alcohol, sometimes something as simple as like a mouthwash or over-the-counter cough products might have isopropyl alcohol. So like basically what's in hand sanitizer, that could show up. So this is actually a VA pain management opiate study reference guide. So this is disseminated to the VA years ago. So just to put it in context. So, while drug screen testing seems necessary for clinical and forensic cases, what is the big deal about using newer methods like blood spot testing? So, what is really the big deal? I know some jurisdictions use this more than others. I'm often talk with people throughout the state and sometimes across the country, and many have never heard of some of these testing methods that are used locally, which is kind of interesting. So clinical use of this is specifically, we're just going to talk a little bit about dried blood tests because this is the one that I've seen locally has caused some issues. So if anyone here has ever had a child, they typically do newborn baby heel sticks. So they use the same methodology. So when you have your baby, they do the heel stick, they put a little bit of blood on a card, and they send it off to the state laboratory for testing. My son, who's about to be 11, hard to believe next month, he tested positive on the blood test for cystic fibrosis. And so we found out about that. Of course, then after that, so they screened for the multiple diseases, and his showed up as cystic fibrosis. we got the positive test. So what happens is you retest the baby with the gold standard test available. So instead of just relying on the blood card said, hey, they have cystic fibrosis, what do we actually do clinically is we test the baby again specifically for that test using a better, more specific test. And thankfully, he does not have cystic fibrosis, but it was a scare for a couple of weeks at the time. So we really think newborn screens alone are not considered sufficient to diagnose a disease given their limitations. One always has to diagnose based on the gold standard test, which in this case for him, thankfully, was negative. Some concerns, contamination during collection, mailing, and processing. Those are all things we worry about. One thing here is if a gold standard test is negative, so again, the send off, the one that when he came back and found out, okay, we're going to test him again, that was negative. So that was the gold standard test. If the gold standard test is negative, then the dried blood test is considered a false positive and simply thrown out from consideration. So basically, we say right off the get go that dried blood test, that was more or less meaningless. The test that we have, the gold standard test, was negative, so they're negative. All right. Specific concerns with dried blood drug testing. It is being heavily advertised in various jurisdictions throughout our state as being superior to urine testing in every way. So it's often being presented as the new gold standard, of which it is clearly not. Blood samples get collected, sometimes not properly labeled. I've seen that. Allowed to dry with others. It depends on where they're being collected and how robust kind of their processes are. But if they're dried together, that can allow for potential cross-contamination, and they do get mailed out of state, so they're kind of in the mail for a while. The actual methods, I've looked into this before, are industry patented secrets. They utilize an untargeted, as far as we can tell, an untargeted shotgun LCGMS method to try and detect everything conceivable. So they basically send it off for every single thing that they can think of, whether it's actually even clinically reliable or necessary or not. So they'll often test for things like certain antidepressants that have no abuse potential, and I have no idea why they're being tested for. Notably, one of the things I've noticed on some of these tests I've seen is the results themselves often have disclaimers such as this test is for clinical purposes only and should not be regarded as investigational or for research. So the tests themselves kind of say you really can't take what our tests say with too much, it's a disclaimer on the test itself, which is kind of interesting. When I think of that, if the test is not really good enough for these purposes, I don't really think it should be considered sufficient evidence to imprison someone or terminate their parental rights. So if the test itself says it has all these limitations and should only be really used for clinical work, which I consider clinical work medicine basically, if it's not good enough for these purposes, I don't know if we should be, saying somebody should lose their kid over it. All right, more concerns with these. Tests simultaneously being collected, which are negative or being ignored. So let's say we've had this happen where we have someone do the blood test and we have someone do a urine test the exact same day, observed urine test the same day. The urine is negative, and then the blood test has this like faint positive. They're basically, I've seen it where people say, oh, the urine doesn't mean anything. We have to, the gold standard is now blood testing, which it's not. So you have two tests. One's a gold standard, one's not gold standard. The gold standard wins in a tie. That's how it should be. Another concern is owner operators who obviously have a clear financial interest in their tests being used have testified that their methods are 100% accurate and reliable. So I've heard this before where they say our tests are 100% accurate all the time. And this is really an impossibility with any testing method, as I kind of go back to the beginning of the slides. There's no test out there, even the gold standard tests, there's none that are 100% accurate, 100% reliable. So that's perjury, basically. Another one is alternate expert testimonies being suppressed. I've seen this before where we've had someone willing to testify that, these methods are, not quite the cat's meow yet, and they've not been allowed to testify, which is kind of interesting. So it's kind of like we only want to hear about how the test is positive. We don't want to hear the alternative. The cutoff levels are set so low that it introduces a greater likelihood of false positives. I mentioned the lower you set the cutoff, the higher likelihood you have of a false positive. So this can be advertised as a benefit, but it actually represents a limitation of these tests. So the lower the cutoff, again, the more noise that you potentially have, the less reliable it becomes. Another concern is the state is spending money on these unproven methods, much more than urine. So the last check, I think it was 5 to 6 times the cost per test to do a blood spot test as opposed to doing a urine test, which is remarkable. Another concern is people are losing their freedom, children, seemingly in the name of profit. I wouldn't blame anyone here that's maybe utilized these because I really feel that, as I mentioned before, folks are being a little misled by false promises from these companies. So, all right. Does anybody have any questions so far? We're going to go over some real life clinical examples of drug screen testing. Anything else, Chantry?
Just a quick question.
Yes.
Like for example, with the false positive that you obtained for your child, that kind of thing there.
Yeah.
When you get the results that it changed, are those included in birth records or are they just later in the medical records? And I'm with Children's Services, you know
Yeah.
what I mean? And the reason I'm asking, I'm thinking, oh dear, have we, you know what I mean?
Yeah. I don't know that question because I'm not a pediatrician.
Yeah.
I would hope that it gets updated. But yeah, because yeah, how many kids are we saying have CF who don't have CF or, maple urine disease or, these weird things I've seen that,
Yeah, because we have a lot of kids when we go to place them, there'll be weird things that come up out of the medical records when we send it to some of the facilities, and they like it sidebars you know what I mean,
yeah.
and what you're doing because 'cause you're thinking, "Oh my, we missed something," and that's what
Hmm.
I was in fact, we were working on one with one child for seizures recently, and it was similar that way, and that's the reason I just wonder because a lot of times when you request birth records come from one spot and medical come from another,
Yeah.
and I never thought about how pronounced it would be, the difference, whether it if it was overturned per se, you know what I mean?
Yeah. Yeah. I mean, I don't from what I understand, is usually the blood spot tests really, I can't say this for certain, but they don't really, we don't put a whole lot of really, like meaning into them at all, other than to guide us to do appropriate testing. So I don't
Okay,
know if those end
okay.
up in their records at all. It certainly scares the bejesus out of parents, though, and
Yeah,
it,
yeah. Okay.
um, I hope that
Thank
helps.
you. I just it was rolling around in my head and I was thinking, "Oh, are we guilty of doing" you know
Yeah,
what I mean? That's where
yeah.
I was. Yeah.
Oh, no worries. Good question. Any others so far, Sage?
Someone had mentioned in the chat that it's a process to get a medical record changed, but it can happen, but most times it has to be pursued.
Yeah. Yeah, and I know with our records, like with ours too, we might have something, let's say somebody's screen is positive, and we see in the, it's documented screen is positive. Really, we don't rely on that too much because if we're sending it out for confirmation and then the confirmation is negative, we clinically know that that test was a false positive. But a lay person, quote unquote, may look back in the records and see that false positive on the screen and get really confused. So that's why you need people independently. It's tough. It's complicated. All right. We'll go on to some real life clinical examples. So these are all things that I've seen or experienced myself. So number one, a patient who previously abused illicit opioids is treated for seizure by EMS and later tests positive for fentanyl. I kind of gave this one away already, I guess, but possible explanation is EMS gave fentanyl in the field to stop seizure. We mentioned about medical records being sketchy. You know what the most sketchy medical records are? EMS records, because half the time they don't give any kind of records, much less a good report to the hospital. So, just being kind of mindful that it is possible that we've given people the very drugs that we're accusing them of abusing. All right. Another example, day report has a singular blood spot test, which is positive for methamphetamines, but not amphetamines. Anybody want to chime in on this one? It's kind of a little bit in the weeds a little bit, but anybody want to chime in? All right. Possible explanation. It can honestly just be an errant finding. So both the parent compound of methamphetamine and the metabolite amphetamine should be present. So when someone ingests methamphetamines, your body will turn a portion of that into amphetamines. Generally, amphetamines do not get turned into methamphetamines in your body, but if you have a test that only shows methamphetamines but not amphetamines, you could basically say, I don't know how accurate this is. If they're both there, they're both strongly positive, that's pretty accurate. But if you only see one, not the other, that's a concern. And I've seen that many a time where people got accused of using meth and the amp part was negative. All right, clinical example 3. A patient was detoxed from alcohol 2 weeks ago, is positive for benzodiazepines and barbiturates on confirmed urine drug screens. So they've been in the hospital, they were drinking, they admitted to their use, they leave the hospital a couple weeks later, their drug screen's positive and a confirmation's positive. What could be an explanation for that?
Treated for seizures.
Yeah.
Don't they use benzos to detox people from alcohol to prevent seizures?
Absolutely. And actually, we're using barbiturates more and more too, because we find that they lower the risk of having DTs, delirium tremens. So the two that have really long half-lives, so diazepam, that's Valium, which, I remember getting Valium when I was a kid for having like a cavity filled or something. That can show up in your system for like 2 or 3 weeks after you take it. Phenobarbital also can be around for weeks. Very strong anti-seizure barbiturate. All right, so we do use them. I have seen people literally arrested 2 days after leaving the hospital because they screened positive for lorazepam or whatever that we gave them in the hospital, and all it would have taken was someone calling us and saying, "Hey, what in the world did they receive in the hospital?" So, another example. Mother of 3 whose first children were taken away on account of old blood spot test, old dried blood spot test. So they were negative, the urine drug screens and hair follicle testing. So this person had like 100 negative UDSs and even did a negative hair follicle test that they paid for on their own dime. They had lost their first 2 kids because of a couple dried blood spot tests. Is about to lose her newborn despite current negative tests. So she has a 3rd child. The tests are all negative now. Even the blood spot tests are negative now. And the legal explanation is that perceived original dishonesty from like 4 years ago about the screens disqualifies her from future parenting. So I've seen this. It wasn't in our county, but they were going to keep a kid away from a mom because they believed that she was lying about her dried blood spot test from like 4 years ago, which is wild. So no use during pregnancy, no use after pregnancy and the new baby, but they were going to take away the kid based on what happened like 4 years ago with dried blood spot testing. So anybody want to chime in what you think could be causing this? All right. I mean, for me, it was really over reliance on blood spot testing. It was also ignoring exculpatory evidence. So we had all these negative drug screens, urine drug screens, which are again, the gold standard of testing. And then also probable bias and stigma directed at the mother. So again, having this idea that, you're guilty until you prove yourself innocent, 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 innocent over again. That's not really legally what we should be doing, but that's kind of what I perceive from that case. Interesting thing too is at the time, I won't go into too much, but I was trying to help out in the situation because there's a patient of ours and they refused to acknowledge that I was an expert witness to testify in the case, which was interesting. But anyways, we'll keep going.
With the DHHR CPS policy that with aggravated circumstances, so if there's been removals before, then they
Yeah.
have to look at the next one that comes along. But in our county, it doesn't seem like a lot of times if there's evidence that points that mothers made a change or these things aren't real anymore, then they may just do a plan and let mom take the baby home, which is always a positive thing, I think.
Yeah, I could understand why the original case got open, or excuse me, the follow-up case was open, but the fact is she was negative all throughout pregnancy and after the baby was born, and she hadn't used in 5 years. And actually, the wild thing about that case was the CPS at the time said she was fine. And they had no issues with her having the kid, and they were going to close the case. And it was the judge and the guardian ad litem that pushed for the case to. They were trying to get her parental rights terminated. It was really strange, very strange. Yeah, it was it like shocked me to my core that it even could have happened, but it did. So, all right, final clinical example. So a child is born via C-section to a mother with no substance use history. Child is purple, not breathing, and requires naloxone Narcan to revive. The baby's cord blood, cord is with a H, I believe, but cord blood is positive for meperidine, which is Demerol. Anybody want to chime in with what this one could have been? So the baby born in an opioid overdose needs medicine to revive baby, otherwise baby dies. What could this be? Take a stab at it.
That Demerol was administered to the mother to help her with pain during delivery.
Yep. And actually, yeah, the OBGYN gave mother too much opioid pain medication for surgery and overdosed the infant. So the reason I bring this one up, this is actually what happened to me in 1986, so almost 40 years ago. They gave my mom too much Demerol. I was almost died. My introduction to life was Narcan. So me and Narcan go way back. I love Narcan. Saved my life. But again, if that had happened, let's say in the era of the opioid epidemic, would my mom have been accused of being a drug addict? I don't know. I don't know what could have happened, but I know, some moms definitely get labeled that way, and I've never had a baby myself, but sometimes the epidurals don't quite do it when getting C-section. So, all right. So, review on drug testing. Drug screening, confirmation, and interpretation is a complicated endeavor. There is no perfect forensic or clinical test. Every test represents a compromise between sensitivity and specificity. The gold standard of drug testing remains the use of urine screens with confirmation. So we screen, but we confirm. Other methods, such as blood tests, remains supplemental. It is not fit for purpose yet, and certainly does not replace the use of urine. False positive being acted on can lead to devastating outcomes for individuals, so we really want to avoid false positives. Be wary of the many entrepreneurial testing laboratories who promise more positive findings. We should aspire to use the best testing methods available to make the most informed legal and clinical decisions possible. So we're not just chasing positives, we're also trying to chase accuracy. And does anyone have any questions at all? Hopefully this answered some things. I'm gonna stop screen sharing here. Chantry is gonna provide these slides too, so if everybody wants to reference them later.